So when we get into individuals who are meeting your threshold to say treat, there's a couple of schools of thought as to what to do next. So it's not just to treat or not to treat, but once the decision to treat is there at whatever point, and we pretty much all agree earlier is better, then there's the strategy of do you start with something safer and escalate, or do you hit them up front hard with something more aggressive and potentially less safe, and then consider what to do later. So the latter has been called induction, but it really, almost no one is doing true induction therapy, which would be hit someone with a therapy that knocks out the immune system. And then down the road come to something safer, right? So induce an immune halt to the disease and then come up with something long-term safer. And that's not really been discussed very much, even though people talk about induction. It really is highly active to start or escalation with something that is safer and we know works. And that's been one of the big debates that's out there, for which there's precious little data, but lots of opinions. So we're going to get some opinions here as well as to, you know, where you stand on this. And let's start with you, Tom.
So I do think that early on there is a window of opportunity, and particularly in patients that present with higher risk. So patients, for example, that have incomplete recovery from an initial attack, patients that have numerous lesions at the time of the initial presentation. So patients that have characteristics that are more concerning, I tend to go towards the quote-unquote higher efficacy medications. Naturally, where we speak in the United States, very often my choices are not necessarily level. So I have to deal with the formularies of the insurance companies, and so there is a compromise at this point in time between where I would like to go with an individual patient based on the data that I mentioned before, and what I can actually do.
Yeah.
So I agree with what Tom said. And in addition to that, I would also take into consideration the location of the lesions, brainstem, spinal cord, bladder dysfunction. If spinal fluid results are available, number of oligoclonal baths might be a predictor of a worse prognosis. And the third thing is race and ethnicity. I mean, in terms of African Americans might not respond as well to conventional modest efficacy drugs as the rest of the population. So I take all these factors into consideration.
Pat?
Well, right now I think it's critically important to treat early, to make sure patients are following a wellness program, and to make sure that any comorbid conditions are being optimally managed. We do not yet have data that says starting a high efficacy agent in everybody, they're going to do better. We simply don't have that data. So we're clearly using shared decision making. I totally agree. If somebody has very active disease and a bad prognostic profile, then efficacy becomes important to me, and I'm going to counsel and discuss with the shared decision making with the individual that it may be very important to pick a high efficacy agent. Otherwise, if that's not the case, then I think there are other needs and considerations that you have with the patient, but then also critically important is to follow them closely, particularly the first 2 years. So if there is unacceptable breakthrough activity, you can make a switch.
Okay. Jamie?
I think I come at this from a little bit of a different perspective, which is that I think the brain MRI is only so good, it's only so sensitive, and there is a lot underneath the surface that we don't really see, and we know when we use sort of novel research techniques that we can see ongoing damage that we can't see otherwise. And I also think that any inflammation in the brain potentially can come back and haunt someone, maybe not even immediately, but may catch up with someone 15, 20 years later. And so I think it's crucially important to prevent inflammation. And I think that we have the data. We know that some of these drugs do better at this than others. Now, it is fair to say that not every patient necessarily will need a stronger agent, that some will get by over the long term doing better on a lower efficacy agent. But I also think that it's hard to really necessarily predict, actually, when you really look at demographic factors and some of the other things that we use, and you study this carefully. I don't think we really have a great barometer about how people are going to do. And I think if you want to wait to see, you may be a little bit behind the curve already. And I also would say about this that I think the treatments are, the profiles of the treatments are changing too. I think we come from a place conceptually where years ago, the drugs that were more potent had more problems in the way of side effects, of higher risk. And I don't know that I necessarily think that that's as true anymore. I think that there are certain drugs that I would argue, I would say that the safety risk, the tolerability is within an acceptable range so that we can use it sooner, insurance permitting.
Good.
So I have been a big proponent of the shared decision-making conversation. Find out what the patient's concerns are, what my concerns are, and kind of mesh what we think is the right approach. But I have found that I'm becoming much more aggressive earlier than I used to be. And I think that's driven by the idea that you see patients over years, even though there's not really much change on the MRI scan, they are having a slow dwindle in their world. And I wonder whether we should be, much more aggressive earlier. And there's some data, not a lot, but some data that suggests that if we really ablate the immune system up front, you can really put the disease in remission, in essence. For how long is questionable. And then ultimately it becomes a safety question, right? We would all be in this conversation if there wasn't some safety concerns to worry about. And I'm struggling with the idea that I'm balancing safety with what the disease might look like over time. And it's not an easy place where we live right now. So, clearly we need more data to support this aggressive induction approach, like the oncologists do, and they basically can, dial things back, or even as rheumatology does to some degree. So I've been moving more into that arena. I'm of the mindset that I think we need to, as Jamie pointed out, you don't see everything on an MRI scan, and I really think there's smoldering disease activity that's happening that we're not picking up, and we need to do something. The other side to that is, how do we do it safely and we don't cause any major problems?